So welcome to this evening's Cafe Med. I'm Ian Stansfield. I'm one of the members of academic staff from the School of Medicine, Medical Sciences and Nutrition. And I'm going to be the introducer for tonight's Cafe Med. And I'd like to begin by introducing the two speakers. So we've got Dr. Andrea Woolner. She's a clinical academic from obstetrics and gynecology. And then we've got Katie Wild, a colleague of mine, who is the Director of Digital Research at the University of Aberdeen. And Andrea and Katie are going to tell us about, I guess, long-term experiments, if I can put it like that. So going completely left field away from Cafe Med for a moment, some of you might be aware that down in Hertfordshire, there's an agricultural research station called Rothamsted. And it's got some long-term field trials running down there where they've taken some plots of land which they've either treated with fertilizer or left untreated. And they started these experiments running in 1850, and they're still running today. These are some of the most world-renowned long-term experiments. And those are all to find out how best to grow crops, to fertilize them, and to make the most of agriculture. You can also have long-term experiments working in medical science as well, and that's what we're going to discuss tonight and what Andrea and Katie are going to tell us about. They're going to tell us about how people were far-sighted enough back in 1949, to establish a database of maternity events, if I can put it like that, which has been kept running up until the present day, and how by joining together those long-term data sets that were established back in 1949, together with modern data analytic methods and trusted research environments, which we'll hear more about, you can really get the most of these large patient cohort data sets. So, joining together some long-term experiment ideas with this concept of big data analysis of these data sets, and we'll see what that can tell us about obstetrics and gynecology in 2024. So, Andrea and Katie, over to you.
Thank you very much for the introduction. Can everybody hear me okay? So, I'm Andrea Woolner. As Ian has said, I am a senior clinical lecturer within the Aberdeen Centre for Women's Health Research here at the University of Aberdeen. But I also lead a double life, and I'm an NHS consultant obstetrician for half my week, and I work here at the university the other half of my week. So we're here to talk to you this evening about this very special database, known as the Aberdeen Maternity and Neonatal Data Bank, or the AMND, as it's often known, which indeed started in 1949, as Ian has told us. So the title of the evening was Data Saves Lives, and so as an NHS consultant, I suppose you could say I'm a bit of an expert on saving lives, or at least I hope to be. And so how on earth can data save lives? Well, I'm going to explain. And one of our dear, very well-respected late colleagues, Dr. Shahini Bhattacharya, looked after the AMND for many years and has supervised and taught many clinicians and researchers, including myself. And she spoke many times of how important the AMND was and is. So like Shahini did before me, I hope to convince you of the same this evening. So, thinking outside of Aberdeen, I'm not going to England actually, I'm thinking wider than that, I'm thinking globally. So, healthcare data is so important, and no more so than for mothers and babies. We know when we look after women in our communities, and we ensure that women live and thrive, we also ensure that children, families, communities live and thrive. Data enables us to see when there's a problem. One of the most important examples of collected data in women's health is maternal mortality figures, meaning how many women die in childbirth. But also many places in the world collect serious events that occur in pregnancy as well, and also the deaths of babies and children. So by having data, we can highlight the problem. We can start to spot patterns, see if our data is worse than another area and compare. And importantly, see where we need interventions, see where we need to do something, and importantly, track if those interventions have worked. But without data, you can't see the problem. You can't hear the problem. It's not there. In most countries in the world, but not all, data is collected on things such as maternal death. The UK, for example, publishes their maternal and perinatal data, which means data relating to babies born, every 3 years. And sadly, in their last report, published earlier this year, we are spotting problems again by looking at the data here in the UK. And on a global spectrum, again, similarly, it's how we know what's going on in women's health, and particularly in pregnancy. So unless you look at the facts of what's going on in healthcare, you won't know there's a problem. And so to me, that's how data absolutely can save lives. Sir Dugald Baird started the AMND back in 1949. He was director of midwifery at that time and was an obstetrician, like me, working in the maternity hospital, looking after pregnant women and delivering babies. He was really ahead of his time. And Sir Dugald Baird was known for his visionary approach to women's health and research. He knew that health was not only about disease, but also about social factors and lifestyle. And essentially what was going on at home was essential to know for the pregnant woman and may impact her health and her risk of illness. What's different about the AMND is how detailed the data was. Its quality is one of its unique selling points for sure. It houses detailed collection on things such as smoking, factors of deprivation within populations. It looks at medication use, other health problems outside of pregnancy, and useful factors such as body mass index. And it basically means height and weight. This means that the analyses that we can do for research using AMND can be done to take account of not just a disease process or a condition or a pregnancy event, but also actually all those social factors that Sir Dugald Baird knew were important. And it's vital for research to be conducted in this way, so we don't make conclusions without all of the necessary factors taken into account. So Katie will tell us a little bit more about how the data was first collected. But essentially, since 1949, we've collected all pregnancy event data for every woman who's had a baby in Aberdeen. Quite extraordinary. And the data goes until 2017, and that's when electronic maternity records have now become the norm. And so there are now NHS electronic maternity records, so the AMND ceased to collect in its current form in 2017. But Katie will tell us more about what we're doing now. There are few maternity databases in the world who have collected the level of detail and the completeness of data that we have in the AMND. By completeness, I mean missing data. So there are often databases, but for example, the smoking history won't be there. So the AMND is really special because the completeness of the data is very good. It holds data on more than 380,000 pregnancies. A key feature of the AMND actually relates to Aberdeen itself. So we know from the AMND, if you have your first baby in Aberdeen, you are much more likely to stay in Aberdeen. Only 2.8% of the population move out of Aberdeen to have their subsequent pregnancies, which is really quite astonishing if you think about it, and a nod to our sometimes grey and sometimes sparkly silver granite city. So it means it's an ideal tool to look at what happens in the next pregnancy, because most women who are in the database, they have all their babies in Aberdeen. So, for example, I'm starting an analysis now to look at pregnancy outcomes after a late miscarriage. So to look to see if the next pregnancy is affected by having had a late miscarriage in the first or subsequent pregnancies. And this is a way of us to look at complications for women who've had adverse events in a first pregnancy. They're understandably worried. If you've had something go wrong in a pregnancy, you want to know if that's going to happen again. And one of the key features of the AMND has been our ability to determine whether that's the case or not. I travelled and work with a group in Manchester who is where there is a Tommy's charity funded research clinic at the University of Manchester, and I couldn't believe it when I went down to visit. And they quoted my colleague, Dr. Myrid Black's paper using the AMND looking at stillbirth. So they quoted this paper and said it actually started their entire research clinic because of the findings from the AMND that found that if you'd had a stillborn baby in your first pregnancy, you were at much higher risk of having a stillborn baby again, and also placental disease, things like having a small baby, preeclampsia. Now, why is that important? Well, we may not be able to stop all of these adverse events, but we can absolutely look for them in the next pregnancy. We can offer care that's different. We can offer increased surveillance and a higher degree of antenatal care. So again, the AMND data has been crucial to plan how we offer pregnancy care. Another paper found, or another research project found, that women who have repeated bleeds later in pregnancy also are at higher risk of complications during that pregnancy. So again, these women are now offered extra scans. They weren't before. They are, because of a research paper using the AMND. A project recently led by Dr. Katrina Young, who was a medical student here and is now a junior doctor working in Glasgow, looked at the impact of how long you push in labour. So across the country, across the UK and across the world, it varies how long women are sort of, not allowed, but are sort of encouraged to push in labour before an intervention takes place. And she looked at outcomes for mothers and babies, such as tears and blood loss, absolutely crucial for then counselling and creating labour guidelines in clinical practice. And we hope to do another project using that database and linking how long you pushed in labour with then other outcomes later in life, including things like pelvic organ prolapse. I recently published a paper in the American Journal of Obs and Gynae, which found having a caesarean very late in labour, and specifically when you're fully dilated, increases your risk of preterm birth in the next pregnancy. Again, why is that important? Well, again, we can look for that. We can warn women about their risk of preterm birth, and there are now preterm birth clinics set up across the UK that provide surveillance for women who are at high risk, and many of them include women who've had a caesarean at full dilatation. Now, ours wasn't the first paper to publish on this topic, but it gained global interest because, again, that quality of the AMND made it a sort of higher quality paper than had been published before. So it gained a huge interest across the world. And why are these examples special? Well, the latter two I've just spoken about are really important because most databases didn't count how long women pushed in labour, didn't count when your caesarean section was performed. You know, they might have known there was a caesarean section, but not that it was at full dilatation. Again, the AMND is very unique in the level of detail it has collected. We found reassuring things. We found that having a postpartum hemorrhage in your first pregnancy doesn't predispose you to hemorrhage again next time. Again, something women can be traumatised by, worry about, absolutely. We have evidence that suggests actually they're not at any higher risk in their second pregnancy. Reassuring, essential for counselling in healthcare clinics. Because the AMND has been running so long, we can also look at families. So we have a huge number, and I've just forgotten the number of how many grandmother, mother, daughter pairs we have. But because it's been going on for so long, we can actually link families and sisters as well, and sons as well, and brothers within the data bank. Again, why is that needed? Well, we know that actually lots of things in pregnancy run in families, and many of the publications from the AMND have showed us that. So papers, for example, have shown that preterm birth seems to be higher risk in families. So if you are born preterm, you're also more likely to have preterm babies. Preeclampsia, a really key condition of pregnancy, affects 6% of women, can be very serious. It runs in families. So now we use family history of preeclampsia as a risk factor to determine who gets aspirin, which is a preventative treatment for preeclampsia, in our clinics. It's right there. In my clinic, there's a whole list of risk factors. One of them is family history. And a paper from the AMND is part of why we know that. My own PhD looked at family history of stillbirth and miscarriage, and I looked specifically at mothers and daughters. Often in clinic, I'm asked if my mother's had a stillborn baby, am I more at risk as the daughter? And actually my research, again, was reassuring. It didn't find an increased risk. Many women, again, worry about that, so having that information is really key. And we were the first paper to investigate looking at stillbirth in families. So the AMND made that possible again, simply because it's been on the go for so long. We're able to do what we call intergenerational research and look at the risks between generations. During my PhD, I also used data on miscarriage. And the AMND is really unique in this regard because hardly any databases collect information on miscarriage. Miscarriage is the commonest complication of pregnancy. Not talked about, quite a taboo subject, but 1 in 5 pregnancies, so 20% or 15 to 20%, will end before 12 weeks, making it much more common than something like preeclampsia. But very few data sources have collected information on it. And in fact, in the UK, the national statistics stopped collecting miscarriage data in 2011. And there's a big campaign now going on across the UK, led by the Tommy's Charity and others, to restart collecting miscarriage data. So we have data on miscarriage in the AMND. And so I use that to look at the risk of miscarriage between mothers and daughters. And it's also been used for other things. For example, one of my late colleague I mentioned, Dr. Shahini Bhattacharya, was able to use the data to see that it's safe and actually in some ways might be better to try again within 6 months of having a miscarriage rather than the historical advice, which was to wait 6 months. So women were used to be told you have to wait. After you have a miscarriage, you must wait for 6 months. Data showed that wasn't the case. And there wasn't really any good data to say we should be doing that. People just decided to do it. But actually, again, Shahini's research showed us, actually, hang on a minute. Why is that important? Well, for many women, they want to try again, but also age is one of the biggest risks for miscarriage. So if we keep telling people to delay, it's actually probably not helpful at all. We've also looked at other events in life. So one of the strengths of the AMND is it can be linked to other data. So for example, we know that from research using the data that women who have recurrent miscarriages are more at risk of cardiovascular disease in later life, because it was the pregnancy data is able to be linked with later health data sets looking at chronic illness and cardiovascular and stroke, for example. Fertility. We have a fertility database that can be linked with AMND. And we know that using the AMND data coupled with types of fertility treatment and information about couples who attend our local fertility clinic, they've been able to show that couples who have subfertility have different risks in pregnancy compared with couples who don't have subfertility. Again, really important, because as a clinician, an obstetrician, I can then risk stratify, so use that information to offer different scans, different clinic appointments, different blood tests, different things, because I know that couples who've had subfertility, their subsequent pregnancies at higher risk. My colleague, Dr. David McLernan, has used the AMND data to develop a prediction tool using the AMND data to tell us how likely couples are to have successful IVF treatment. And that's being used across certainly the UK and also, I believe, in the US as well. We've also linked pregnancy data to other outcomes, endometriosis and cancer in women. And my colleague, Dr. Saraswat, has done a lot of work around looking at influences from pregnancy and outcomes of pregnancy in women with endometriosis. We've had studies look at so many things. And we have a website on the Aberdeen University website where there's actually a whole list of publications that have come from the AMND. So if you type in AMND into the search bar, you'll find them. Anemia, weight between pregnancies, time between pregnancies, a huge number of things. The AMND has one of the most detailed twins data sets in the world. And again, countless contributions to research around twins and things such as, again, safe thresholds for when we should recommend twins are born by. So again, something I literally use every day in clinic from the AMND. More recently, we've looked at the history of cervical treatments and precancerous cervical changes. So like when you go for your smear, those changes that are picked up and their impacts on pregnancy as well. An AMND paper suggests that women who've had cervical treatment are more at risk of preterm birth. So it's back to that risk again, identifying women who might be at higher risk of adverse pregnancy outcomes. But actually, myself and colleagues are now looking at whether or not the HPV vaccine, which is now offered to all teenagers in the UK, whether that's reducing the risk of preterm birth or not. And we're hoping to publish that paper soon. We've also looked at exposures in pregnancy. So when you're in the womb, do certain things affect your life? So for example, smoking, mother smoking in the womb, we know from research conducted with the MND, increases the unborn child's risk of miscarriage in their own reproduction. We know things such as exposure to air pollution has effects on babies as well when women are pregnant, and many studies led by Dr. Steve Turner on that, and looking at childhood outcomes. So, the data held within the AMND has literally saved mothers and babies' lives, in my opinion, by improving our knowledge. And if I haven't convinced you of that, at the very least, I hope to have convinced you that it's certainly improved their lives, improved our understanding of pregnancy disorders, and how we should manage pregnancy, and how events in pregnancy shape not only the mother's life, but also the child's. And we haven't stopped using it. It remains a key data source, coveted by many other researchers, and continues to change how we practice. And as the collection ceased in 2017, Katie will also tell us now about what we're doing going forward using this key data.
Okay, so now that Andrea has told you about the vast research that can be done with the data, I'm going to just take you through the way we look after that data that allows this research to be done in a safe and secure way. So as you can imagine, over the last 75 years, this has changed considerably. So before the age of computers, the way extractions were done was using a knitting needle. Now, some of you may have seen this before, but effectively, the hospital records would have had little holes around the outside, and they would have been either half a hole or a full hole. And you'd pop the knitting needle in. So as Andrea said earlier, they had research on stillbirth. So there would be a name of a stillbirth, and it would be clipped if it was in. You stick your knitting needle in, and you'd pull up all the records that had a stillbirth. Now that sounds like a good idea until you have to put them back in order for someone to find them, but that's how it was originally done. Moving on, we then moved to databases, different types of databases, and for the AMD data bank, we had a group of data entry staff who would review the medical records, they would read through them, they would then code them, and then enter that information into these databases. For those that are maybe interested in what they were called, we used to have something called a SIR database that was around in the 80s and 90s. And then that moved to an Access database. So yes, a Microsoft Access database was what we were using all the way up until 2017. Now it did have a SQL Server backend, but that was the technology. And as we said, the data entry stopped in 2017. But that doesn't mean that we're not still collecting this data. We now access directly the maternity records that the hospital staff are using. This is in a system called BadgerNet, and we can do the data extractions directly from that. But it's not only the extractions that have changed the way in which we provide data to the researchers over time. So I'm not going to tell you how old I am, but to give you an idea, I do know what a floppy disk is. Facebook came out when I was halfway through university. So when I first started here as a graduate trainee, transfer of data, so if we wanted to link this data, came to me on a CD. That CD was sent recorded delivery. It came with a nice secure password, so none of this 20 characters long. It came with the weather in Edinburgh and the date it was sent to me. So you can imagine the passwords were maybe quite similar. There wasn't that many sunny days in Edinburgh. And we would then do the extractions, we would send them the same way. If we were releasing it to researchers out with the university, they would maybe be sent on CDs. That then advanced to potentially using a USB stick, but people had to come and collect it. And we would, at some point, send it by email until it changed, and all the file types that we used to send it by, you now can't send by email. At the same time, though, across Scotland, there was a lot of work being done through the Scottish Health Informatics Programme, the SHIP programme, who, following a review of using healthcare data, they set out a charter, a safe haven charter, and they looked to create these safe havens. Now, over the past 12 years, we've moved from safe havens to trusted research environments, or a TRE, unless you're in England, and then it's an SDE, a secure data environment. But the Safe Haven Charter was set up in Scotland, and we created 5 safe havens across Scotland. One of these was the National Safe Haven, so comes out of Edinburgh and goes by the name of Idris. Then, just a little bit of background, in Scotland there are currently 14 health boards. Within those 14 health boards you have 4 nodes. Within each node you have a medical school, and that's where these 4 safe havens were created. So we have one here in Grampian. We are a joint safe haven between the university and the NHS. There is then one in Tayside at the University of Dundee, one at the University of Edinburgh, and one at the University of Glasgow. Now, these safe havens, because they are node safe havens, mean that they do not just have, or should not just have, the local, like Grampian data. We are looking at having Highlands and Islands data come in. The same with HIC, which is the Dundee safe haven. They have data from Forth Valley and Tayside. So when these safe havens, or TREs, were set up, they focused on providing 5 safes, although admittedly 12 years ago it was only 4 safes, and now there's apparently a 6th one on the way. So what are the 5 safes? We have safe data, and that is that data is treated in a way to protect confidentiality concerns. So how do we do that with the AM&D data? Well, we do that by, when we provide it to a researcher, they do not get identifiable information. So they don't get names, they don't get addresses, they don't get date of births. What they do get is they get what we call a pseudo ID. So we don't completely anonymize the data, we give it a key. That means that we can link it back if we need to. For addresses, we don't give them postcode or anything like that, but we will give them a measure of deprivation, or maybe a measure of if it's a rural or an urban address. For date of birth, we tend to replace it with ages. But you can imagine, even then, there's maybe some sensitivity within this data set that we have. So potentially they're under 16 births. So even then, we don't provide the exact age for anyone under 16. We effectively, anyone under 16 is just badged as being 16, and researchers are informed that if they've got a 16, it could be 16 or under. So that's how we focus around the safe data. The safe projects. So research projects are approved by data owners for public good. So for the AM&D data bank, we have what we call a steering committee. That's a committee that improves the projects. So you have to fill in a form if you want to do research. Even if you're an NHS clinician, you still have to fill the form in. And then that goes to a committee that is made up of NHS clinicians, data managers, statisticians, researchers, but most importantly, members of the public that give us a lay or their personal view of what they think about this research. So these research proposals are reviewed, they're checked that it's scientific sound, that the requested variables are enough to answer the research question and not too many. So you can't just come along and say, I want everything in the data bank. You have to choose your variables that you're interested in. The third safe is what we call safe people. And that's that researchers are trained and authorized to use data safely. So we've already said that they have to have their steering committee approval. And then the data that comes out of that data bank is released by the safe haven, or our TRE. And for a user to access that TRE, they must have the permission, but also they must have evidence that they've completed a training course that is aimed specifically around working with healthcare data. You know, focusing on the confidentiality that comes with that, the governance that comes with that, and they must review that every 2 years. So that means if there's any changes in legislation, the researchers accessing this data are up to date. Number 4, safe settings. A TRE, or safe haven, prevents unauthorised use. So what is a safe haven? So it's effectively a lockdown environment. It does not access the internet. The researchers can't access their own data. For the researcher, it looks like another desktop. It's a virtual environment, so they can access it from their office. There are some data sets, not the AIM&D, where there is a need to go to a physical location, but for most of these projects, you don't need to do that. But when you're in it, you can only have the data set that you've been given. The researcher may bring their own code into the environment, but even then that's checked by people within the safe haven before it's uploaded. Most importantly is a researcher never gets to take away the patient level data that they're given. It's all kept within this environment. And again, another thing to just be clear, the data provided to them is only enough variables to answer their research question. So the 5th safe is safe outputs. And you may be thinking, if you've got this lockdown environment, what does the researcher take away with them? How does Andrea publish on that if we're not allowing the data to be taken away? And that's because we allow the output. So the researcher must put together their tables or graphs, but these must all be checked by our trained staff to assess the risk of potential identification of people from it. Now, data is classed as being identifiable if a person is able to self-identify themselves. So that makes it quite tricky when we're doing some of these outputs, but we would put, say, numbers under 10, we would only ever release them as being less than 10. We would never say there were 5 or 3. And our trained staff need to look at previous releases to make sure that you can't link it back and you can't start to self-identify these people. So that's how keeping data safe for researchers has changed over the years. But what do we think it might look like in the future? I'm just back from the Health Data Research UK conference, which had the tagline, "The Grand Challenges in Health Data." And what was apparent at that conference was that the TREs, safe havens, SDEs, whatever you want to call them, these secure environments are here to stay. And as a team within Grampian and at the university, we've worked really hard over the last 12 months on funded projects to look at bringing in tools to help us with some of the statistical disclosure, maybe automating that, and also to help with the transparency on what we call provenance, so that it's very clear that as a researcher and as a member of the public, you know how Andrea has got to her various outcomes. So it would show all the steps related to how the data was collected, how it was extracted, and then how it was coded to come up with these results. Now, this is great, and we're keen to work with this, but at the same time, requests are changing. So certainly over the last 4 years, we've seen a big request for people to have access to medical letters, to the images, which means that we, as a safe haven, are having to change the way we anonymize data or pseudo-anonymize data, because when you've got an image or you've got a letter, removing the personal information makes it very obvious if you've got a lot of records, if you've missed it. So if you think there's a hospital record and it says Katie Wilde on it. Now, if we don't redact that and it says Katie Wilde, you know it's my medical record. So what we've been doing is we've been doing something called hidden in plain sight. And rather than saying Katie Wilde, it might say Andrea Woolner. Now, you don't know whether Andrea is the right one or not. So we're doing things like that. We're testing these processes. So going forward, I'm not quite sure what the next 75 years is going to look like when it comes to this. But for us, we will be looking at ways to automate it. We're looking at ways to keep this data nice and secure. But at the end of the day, our biggest thing is enabling researchers to be able to use this data so that they can do the hard job and start to save lives. So thank you very much, and I'll hand over to Ian for questions.
Thanks very much, Andrea and Katie. That was fantastic.